Cool. Thanks,
So
David.
for people all over North America that are on now, we apologize. I was just telling Steve and Glenn. Steve's from Dental Intel, and Glenn's the dentist that is our expert tonight on lasers. We feel like Janet Jackson a little bit, technical difficulties, and somehow Zoom did not allow you to log on, and we apologize for that. So we, it's like 10 minutes late, but stay on, and we really appreciate that. We're going to have some fun tonight. Glenn and I guess we were talking, we've known each other for 15, 16 years. And one of the first times we spent any time together, and Glenn is a Vancouver, practices dentistry in Vancouver. So it's always nice to have a clinician as an educator, practices Vancouver. And we had the opportunity to speak together in a hands-on course in Costa Rica. So neither Glenn or I could really pass that up, right? And so Hoya Cambayo invited us down, and it was a very rustic resort in Costa Rica in the Oso Peninsula. For those that have been to Costa Rica, it wasn't where the Four Seasons is at all. It was right across from Panama. So it was in primary forest. It was gorgeous. But it was a resort owned by someone from San Jose, California. And the food was amazing. The grounds were amazing, but it was rustic, right? But Hoya Cambayo had previously sent 30 pig jaws so we could do hands-on with hard tissue lasers down there, right? So Glenn and I have done other courses where we've done hands-on with pig jaws, and it's never been a problem, right? The pig jaws get sent ahead of time, they get put in a freezer, and then we show up and we do the course. And the nice thing about pig jaws is very similar to human jaws and human skin, where we can do soft tissue as well, hard tissue, osseous, as well as teeth, right? So, we get there and we're looking around saying, where's the lecture? And we get there a day before, and the guy says, oh, it's over in that building there. And we're thinking, this is going to be really cool, right? And we said, did the pig jaws show up? And they said, oh yeah, they showed up 3 days ago. And it's like, thank God, these pig jaws are getting sent from the US to Costa Rica. Are they really going to get here? Because everyone's anticipating hands-on on pig jaws, right? So we said, well, let's go check them out and make sure everything's cool. And they did arrive, right? So this was a enclosed single large room building. We open it up, and it smelled like anatomy lab when you were in dental school, but worse. And it was like, holy cow, what the heck's in here? Well, the people at the resort had no idea what these pig jaws were. So what they did is they got them, and they were all on dry ice 3 days earlier, and they stuck them in this lecture hall and closed the door. And the weather was 100 degrees. And they didn't have air conditioning because there was no reason to keep the air conditioning on until the attendees showed up. So we go in there, and it was a bad deal, right? So we had 1 day. So they had to air out the room. They had to get rid of these box of 30 pig jaws. So we think, what are we going to do here? And the crazy thing was, this resort was primitive but nice, and they didn't even have internet. So we thought, what are we going to do? How are we going to get pig jaws in a resort that doesn't even have internet? So the owner of the resort came over and said, I can totally get you pig jaws. Let's go talk to the chef. So go over to the chef, and we tell him, and he says, yeah, we can get pig jaws. And so we had 1 day, and the next day the chef comes in and says, is this what you were looking for? And for those that have done any hands-on courses with pig jaws, it's a sectioned jaw. They take off the head, they take off the face, and you've got a jaw with gum tissue there, right? So he comes in, and it's the whole freaking pig head. And he had 30 of these pig heads, and he says, is this what you guys were looking for? It's like, not exactly. Can you skin them and cut them in half? So that was kind of our introduction to spending some time together. And Glenn is a great guy, lectures all over the world, probably the most knowledgeable person I know on lasers, both hard and soft tissue, very into microscopes. So his photos and videos are right on. And I really appreciate taking the time, Glenn, because you worked today. I did not. You worked today, and you rushed home to spend some time with us, only to deal with technical difficulties, but with a smile. And we really appreciate you coming on. So for those that are on, this is live. You can ask questions. We want you to use the chat, not the Q&A. And the chat, I'm going to interrupt Glenn occasionally if it's apropos with your questions. At the end, we'll have about 5 or 10 minutes. You can ask questions. Glenn, will you give your email address if you haven't posted anywhere that if they do have any questions about some of the stuff you're doing, you have your email?
Yeah, I can do that at the very end.
Okay.
It's no problem at all. Yeah,
Let's
no problem.
do that. Steve Jensen, who is our troubleshooter right now, he's the host of this presentation from Dental Intel. A lot of you use Dental Intel. Most of you know now, because this is now our, what do we say, 12? Is this our 11th or 12th episode? 12? 12. So
yeah, this one's 12.
Wow, it's amazing how fast that went by. I changed my practice software just so that I could use Dental Intel. It's really the only way I can really look at the metrics in my practice from my cell phone if I need to. I would urge you to look into that if you already haven't. I appreciate their generosity and their hospitality in sponsoring this, along with Utah Valley Dental Lab, which I'm the director of education. We do our live patient courses through Utah. And obviously they do all my ceramics and implant dentistry. So we appreciate our sponsors. Without further ado, since we're running a little behind, Glenn, let's see what you got, man. I'm looking forward to it.
David, thank you so much. And I'm glad that some participants have managed to make their way in. My topic tonight is the adjunctive role of lasers in aesthetic and implant dentistry. Lasing is amazing. And I'm a wet finger dentist, so I'm going to try and not bore you with laser physics and laser science and try and show you clinical cases and treatment outcomes. My dad was a dentist. He and I practiced together for 18 years, and he passed away in May of this year. I learned an awful lot about him. I always try and think of him, and so I'm dedicating the lecture today to him. He was a great friend, a really good dentist, and a gentleman. David was talking about our memories in Costa Rica, and this is a photo from that course in 2007. It was a really rustic event, like David said. Sorry, David, 2005, and we did fishing, we did tours in the jungles, we had a lot of laughs. I got to know David personally. I always looked up to David for his tremendous knowledge on all things aesthetics, and got to know him as a person and really enjoyed that. And I've stayed in touch with David over the years, and really this was the foundation of that particular friendship. David looks exactly the same, right, Dave? Hasn't changed a bit. And we went out fishing, deep sea fishing, and we were actually going for sailfish that day. And it was, as David said, that setting was amazing. It was in the Osa Peninsula, and Costa Rica was amazing. And Tom Haney was the president of Hoyocom Bio, and he's pointing at David there because David's the man, but he's also pointing outside because there are porpoises everywhere, and wherever there are porpoises, you know there's going to be fish. And so there you see the porpoises, and sooner than later, next thing you know, David lands a very large sailfish, and I noticed the guns there holding the fish, Dave, and you're exactly the same and looking exactly the same. But I noticed that even at that age, you were very cautious when the fish started to get let loose to not get poked by the sailfish fin. So, as I mentioned, it was catch and release. It was beautiful. Got an opportunity to talk about all things dentistry, and the setting was quite incredible. There. We also went over to the other peninsula in Golfito, and just a couple more photos of some of the parrots, and David holding a scorpion orchid. And you can see that here from 17 years, almost 17 years ago. So that was my introduction to David. And I've always kept in touch and admire everything that he speaks about on aesthetics. So I was really honored to be given an opportunity to come and talk to you today about lasers and implant dentistry and aesthetics. So the lecture is going to be broken into two parts. First part's going to be on aesthetics, and I'm going to talk very briefly about the types of lasers available in dentistry today. And then we'll go over some clinical cases and show you some soft and all tissue clinical cases. And then in the latter part, the last hour, I'll talk a little bit more about lasers in implant dentistry and show you some of the areas where we're using lasers for different phases during implant therapy. I began using an operating microscope in 1997. I've been in practice for 34 years, and I do all my work through an operating microscope. We have 9 ops, and I have 9 scopes, and I do all my work through it. Not saying you have to, but I'm saying that's how I get my video and stills. So you can see here a laser being utilized for crown troughing. I started using soft tissue argon lasers in 97 and have been using erbium lasers, all tissue lasers, since 1999. So I've had a fair amount of experience utilizing them in the practice. And in the beginning, I used them like everybody else for restorative purposes, and I don't use them much for restorative now, mainly for soft tissue and for bone and working around implants, but not as much for restorative anymore. Since 2014, I've spent most of my time with BioLase lasers, the I+, the Express, Epic, the Epic Pro. And they're great products. They're reliable. They make soft and hard tissue lasers, and the company's been around for many, many years. So with that said, I know Anton is on the call here today. He is the account manager in San Diego. Here's his contact information, the toll-free and direct. So if you have questions about BioLase or about the products and you want to know a little bit more about it, feel free to contact him. I will be sharing his this same slide at the very end of the lecture as well, should you be interested at that point. When you look at lasers, I want to always show you something that's current, because I feel like, people think, oh yeah, you're showing me a bunch of slides, but this isn't, real dentistry. And I want you to know that I do use them. And this was from yesterday. I literally took 2 cases, one on implants and one on aesthetics, and just put it in to show how the laser was being used. So this patient was treated in March, where I placed 2 implants guided. And a patient came in yesterday, finally, after having 6 months away, and they were in a summer place and they didn't want to come until September. And she came in and I said, how are things going? She goes, I lost a part. I don't know what it was, but I lost it about a month and a half ago. And I look, and this is what I see. One of the healing abutments is gone. And you're scheduled an appointment to take an impression for the final stage, and I want to get her finished. And, I'm missing one healing abutment. It's grown over. So we're able to, you see here in close-up view, be able to use all tissue. This is an Erbium all tissue laser. And we're able to the videos should be a little bit choppy, but it will improve in time here. We're actually able to uncover the implant here and use the laser in real time with water. And one of the things, compared to a burr or compared to a tissue punch, is you really have a clean field to watch. And the fine spray really takes the blood and distributes it. And there's a little bit of cauterizing going on. There's a little bit of blood there, and I'm able to remove the tissue and get right back down to the shoulder of the implant. And you'll see here, I'm blowing a little bit of air, you can see the shoulder, and I was able very quickly to uncover the tissue and be able to do the impressions the same day. Saving, no flap to uncover and no blood. And this is immediately there afterwards, able to put a couple impression posts in, close tray, and take our impressions the same day. Put the healing abutment back in. These impression posts are the same diameter as the healing abutment. We're able to put the healing abutment back in, and it really made a nice clean surgery, and something that, we all have these on a daily basis, where a patient comes in and unfortunately they do something that you didn't expect. And so I was able to pull the laser out and just uncover the thing. And yeah, you could do it with a tissue punch. It might not be quite as clean. It might not be quite as easy to see it. You might not know that the tissue would be off the shoulder like I showed you there. But yes, you can do it with other products. But it was easy to use the laser, and that was part 1. Part 2 yesterday was this particular case. Patient coming in with 2 old porcelain fused to metal crowns, wanting them to be replaced. I'm seeing a lot of patients who are retiring and wanting to have some of their dentistry replaced. And partly because I'm 60 now, and partly because patients are retiring at an early age. And here in Canada, they say, can you replace the old dentistry? And this was part of that particular patient. So we sectioned the crowns, and when I sectioned the crowns there, I always thought that the gold was going to be a little thin on the posterior crown, the second molar, but indeed it was not. And when I removed the crown off the second molar, you can see there doesn't a lot of tooth structure left, but it was the tissue in between the first and second molar that was of concern to me, because as you'll see, the margin on the distal of the first molar is quite deep, and actually it's on resin, and I had to go and clean it up. When I did clean that up, you can see the tissue, you can see it's deep, you can see it's sort of overlapping on top of it, and shot through the microscope, if you were to look, you would actually see that right at the junction between the resin and the two structures, a gap, and it's being held in by a pin. I could see it was actually moving the resin. So I remove it, and there's caries, and of course, you know, you're going deeper and deeper, and the tissue's bleeding. You're trying to do a core buildup, and we use an isolite. I just put this in there just to show you, because people will say, "Where's your rubber dam?" And I'm using an isolation device, which I find to be quite handy for these kinds of cases. So that's the isolite in place, and you can see the tissue and how billowed up it is in between. And because this was part one, I did this yesterday. Obviously, I don't have the final results, but I'll show you a similar case to show you the tissue healing. But we're able to use the laser and able to actually first trough during the round with the laser to create a little moat, almost like cord. I used the laser as well to disinfect the dentin, as you see here. And then we built the tissue up and did the laser troughing. And I literally ablated the tissue in between so I could get a good margin. And you can see a high magnification here, a good margin. And I have an iTero scanner that we just set up last week, so we're using it for ortho. I haven't actually used it for any restorative cases, so we're still using traditional putty and wash and full tray here, and some provisionals. So the laser was really helpful in allowing me to keep it dry for my core buildups and also for tissue management. And it's really a wonderful tool for tissue management, both in indirect and direct restorations. So those are just two cases, and I just wanted to share with you that, that was from yesterday, and we are using them on a daily basis routinely for many different things. So I'm going to share some of those cases with you today. Some of you who have lasers may be familiar with some of the products that are out there. The diode lasers are small and portable, and they become quite a staple for mild to moderate tissue removal. Some people find diodes to be slow, to be frustrating, but they are popular because of their price point, because of their size. The all-tissue lasers are bigger. This is an Erbium chromium from BioLase. There are Erbium YAG lasers out there from products like Photona and other companies that also are all-tissue lasers. These can cut bone, dentin, cementum, caries. They can cut everything. And unlike the diode, they're a little bit bigger in size, a little bit more expensive. Nd:YAG is a laser used for perio, both for failing and ailing implants and for periodontitis. And also the CO2 lasers are a soft tissue laser that are out there that are a rapid cut. Some of the surgeons like it because it can cauterize quite quickly and cut quite quickly. A new product into the market is the all-tissue CO2. This is known as the Solea laser, and that laser is fairly good for restorative purposes. It's a fairly big product and fairly expensive, but it is quite a nice laser for cutting for restorative purposes. And finally, there are lasers out there that only are used for low-level laser therapy, for wound healing and pain control. And I'll talk a little bit about this in the implant section. I'll mention a little bit about it, using lasers for low-level laser therapy and photobiomodulation. It's something, if you have a diode right now, you can use it. And I would strongly encourage you to start using it because really it can make a huge difference to those of you doing surgery for dry socket prevention, for lingual paresthesias after injections, for wound healing, for pain control. It really is a marvelous tool. And almost every study that comes out now that's done shows that low-level laser therapy is the real deal. It's not smoke and mirrors. So I strongly encourage you, those of you that have a diode laser, to look into it. And I'll talk a little bit about it during the latter half of my lecture tonight. I'm going to focus on diodes and erbiums because that's what I know the best. So I'm going to focus a little bit on diodes. I'll mention the Nd:YAG, and we're going to focus today on soft tissue lasers, the diodes, and the all-tissue lasers, which are the erbiums. When you compare the two, the diode lasers on your left are soft tissue only lasers. They cannot be used to cut dentin. They cannot be used to remove veneers like the all-tissue lasers can. So please do not expect that a small $4,000 laser is going to do what the one on the right-hand side does. The small and portable features of the diode make it popular for small tissue removing and cauterizing. It is good for low-level laser therapy, so if you're not using your diode much, look into using that. It's great for hemostasis, whereas the erbium laser on the right is faster cutting and, in my opinion, faster healing. Diodes are used for soft tissue only and for low-level laser therapy, whereas the all-tissue lasers, the Erbium lasers, can be used for a multitude of factors, including restorative, implants, endo. The cost is significantly different, as is the size. You're looking at $4,000 to $8,000 US for a diode laser, and you can be looking at $50,000, $60,000, $70,000, and in the case of Solea, you can be looking at $125,000 to $150,000 for that large laser. So you're talking apples and oranges here. You're not talking similar products, similar price. When you look at diode lasers, they become popular because they can be used around metals, such as implants. They can be used for gingival troughing instead of retraction cords. And there are articles out there that show that it can be, in fact, less traumatic to the gingival tissues. It can be used for simple frenectomies and surgical procedures. And finally, it can be used in hemostasis for things like coagulation of venous lakes and vascular lesions. So diodes are well absorbed in hemoglobin, and they are soft tissue only lasers. There are challenges in using diodes, and I hear these challenges. When we've done courses, people will say, I cannot seem to cut. And part of the reason is many lasers, they require you to initiate the tip, usually on articulating ribbon, to get this orange glow that you see on the right-hand side. That orange glow means that the laser tip is functioning as a hot branding iron. It's basically a hot tip. BioLaser in some companies, I'm not sure, but I know BioLaser for sure makes pre-initiated tips that eliminate this. But anytime you cut soft tissue, you must have the tip initiated. You do not use the tip initiated if you're using it for photobiomodulation or for low-level laser therapy, for canker sores. But anytime you're cutting tissue, you need to have an initiated tip. You need to slow your hand speed down. Electrosurge, you can just take your hand and go across the tissue and cut it. But with diode lasers, you have to move in small incremental light brush strokes, 1 or 2 millimeters back and forth. And if you try and drag the tip across, only the end cuts. So the side of the tip will not cut, and therefore you will find that either the tip breaks or you get bleeding. So you have to slow your hand speed down. The speed of ablation is much slower than compared to other wavelengths or to electrosurge, and people get frustrated with that. So there are lasers like the Epic Pro, which is a very powerful laser out there that can cut faster as a diode, but it comes at a cost. And that cost is post-operative discomfort at times through more charring and more post-operative lateral thermal damage. It is specific for soft tissue, meaning you can't cut bones. So if you're cutting a tissue around a class 5 and you suddenly don't seem to be cutting anymore, it's probably because you're on bone or periosteum. So again, please, please, please realize that if you have a diode laser, it's good for cutting soft tissue. It's not good for cutting bone, cementum, veneers, decay, etc. And the depth of penetration compared to other wavelengths is deeper. So again, the longer you use it, the more likely you're going to have lateral thermal damage. And these are just some of the challenges of using a diode.
Hey, Glenn, can I interrupt you here?
When you compare it to the Erbium chromium, I wrote a chapter in 2004 at that time on using lasers for restorative purposes. And you can do anesthetic reduced restorations where maybe not as much anesthetic is used. And again, early on, I did a lot of this. It's just slower than a handpiece. It's 1/3 as fast. It cannot remove amalgam. It cannot cut crowns. So I'm not doing as much, maybe class 5s and some pedo cases if I have them, or what we do. We can do closed flat crown lengthening. I'm not saying you have to. I'm saying it is possible to. And if you're doing mild to moderate crown lengthening in the upper anterior or on a broken premolar where you're trying to find out where that break is subosseous, you can use your laser to do this. By all means, open up a flap. By all means, use traditional means. I'm just telling you that there is research and articles out there from people like Hugh Flax showing that closed flat crown lengthening is possible, and I will show you a case. Removal of porcelain veneers and porcelain restorations is something that's become very popular since 2009. And I can use the laser, the all-tissue laser, to remove zirconia, to remove porcelain veneers, to remove all ceramic restorations, often in under a minute. I'm not saying always, but it is very, very common. I will show you cases in real time where we're using the laser on the right here, the BioLase I+, and we're using it 4 to 6 watts, depending on the type of material, whether it's Emax veneers versus a zirconia crown. We're using them to remove the product without damaging the underlying tooth and without having to cut the crown off. So let's talk about direct tissue, direct restorations and tissue management. In composite restorations, when we're dealing, we need a dry field. And this study here from 2020 from this particular group showed that a pulse diode laser could be used for consistent tissue ablation in the aesthetic zone and that it was safe to do. We're trying to limit the tissue as a barrier, like I showed you in the last case, in the first case that I showed you on the before I started. Tissue can get in the way, and we need to manage that tissue. Can you do it with cord? Can you do it with alternative means? For sure, for sure. But I am telling you that you can also use diodes and all tissue lasers in aesthetic dentistry. So here are some old silicates on an upper central, an upper lateral. The silicate restorations that are stained, the patient wanted them removed. And once we remove them, you can see that the tissue is very close to the gingival aspect of the preparations. So one nice thing with using a diode laser is that you actually can use a diode laser to trough and push the tissue back. So this is a small portable diode laser. You can see it's initiated, the tip is glowing. And we're just using very light brush strokes, 1 millimeter, 2 millimeters at a time, to trough around the margin. The charring that you see should be minimal. If you start with 1 watt and it starts to drag up the settings, if you're going to use 5 or 7 watts, for sure it's going to cut faster, but you're going to get a lot more lateral thermal damage, and you're going to get postoperative discomfort and a greater risk of recession. People ask me, how do you get rid of the charring? And it's easy. You just use a little bit of hydrogen peroxide on a microbrush or on a cotton pellet, and you can get rid of that charring. So I'll show you immediately postoperatively after the diode, and now after the hydrogen peroxide was used to remove the debris. Not only is the tissue pushed back, but when we put the barrier in or the matrix in, you get very little bleeding because you've actually conditioned the tissue. And so it's nice because you don't have the bleeding start as soon as you put your matrix in. And I know across North America, in other areas outside of Canada, that people floss, but they say 8% of people floss in British Columbia. And I know that bleeding interproximal tissue is never an issue where you live, but unfortunately it is an issue here in Canada. So here are the restorations. The tissue will creep back immediately, and you've been able to control those restorations and control the tissue in that area very easily by using the diode laser. So we use this routinely, particularly in class 5s, where the caries is going underneath the soft tissue. And I don't know how it is there, but patients are now have been told that if you live to 65 and you're not taking any medications, you have a 1 out of 2 chance of living to 90. And that's great, except that you're on medications that dry your mouth out. We're seeing root caries everywhere. And these are difficult, challenging caries to control. And the lasers can be incredibly helpful for your tissue management in direct restorations. Here's an indirect restoration where we're replacing an old first molar porcelain fused to metal crown, similar to what I showed you in the first case. But in this case, I'll show you both the initial prep and also the tissue healing. So you can see there's some recession. Patients are always asking, what's that dark line? And you know, it's the root surface of the tooth. And we see a lot of these restorations that need to be replaced. So cut through, like I did in the first case, through the porcelain first, now through the metal, and we remove the restoration. You can see here the restoration, and you can see the cement that's left behind. And you can see the caries on the interproximal area. So once the caries is removed, you have a preparation, and you can see that the tissue interproximally is inflamed. And I always hated using cord. I'm just not I'm not fond of cord. I still use it occasionally, and a patient is very picky, but I try as much as possible to use the laser. What I find is with cord, as soon as the first impression came out, if I took the cord out and the first impression wasn't good, the second impression was even worse because the tissue was slumping back on your margin. I hated using hemostatic agents because patients hate the taste of it and would always be complaining about the taste of the hemostatic agents. And unfortunately and approximately, you would always end up with issues. So on the right, you can see the diode troughing using a diode laser. And you can see the impressions there. The tissue has been pushed back, just like in a two-chord technique. This particular study from 2018 compared retraction cord to the diode laser, because I know what some of you are saying. Oh my gosh, the tissue looks so chopped. My tissue doesn't look like this, and I'll never use a laser. You're butchering it. Well, they compared retraction cord to the diode laser, and the conclusion was that the diode laser, in fact, required less time, was simpler for the operator, and was more comfortable to the patient than a two-chord retraction technique. Is this always the case? I'm just telling you that there are studies out there in the American Journal of Dentistry from 2018 showing that a diode laser, in fact, can be utilized routinely for your tissue management. Here's the impression. You can see the impression here in light and heavy body, and the provisional was placed. Patient came back 2 weeks later, and what's routinely interesting when you take these temporary crowns off is the healing on the tissue is absolutely incredible. So when you look at the tissue, you'll find that when the patient comes back, they'll say, yeah, sometimes I got a little bit of sensitivity for the first day, but then it was gone. And the biggest thing is you'll find that they often have tampon in the trough, and that will, you have to be a little careful with that, removing it. But there's the tooth, there's the zirconia crown, which are becoming quite popular. I know some people would lean towards Emax. In this case, we used a zirconia crown. You can also use erbium laser or diode lasers in the anterior cases. And this is an older case, but I want to show you this because I've been told, well, I use them in the posterior for Mrs. Smith, but I'll never use it on my picky patients in the front because you're always going to get tissue retraction. You're always going to get exposed margins. And I'll tell you that if you use lower settings, you take your time, you can use routinely diode lasers for your cosmetic cases. This is a patient that came in, had two old upper class 4 restorations. If you're somebody who loves doing class 4 restorations, one option would be to remove these as an older case and use some tinting agents and put 2 new class 4s in. But on top of it, they also didn't like the crowding and the position of the teeth. So we talked about a lot of options, and they decided to do 4 veneers. We prep the teeth and remove the resin restorations. And at this point, we are ready to do the tissue management. And here we have the diode laser being utilized. This was a Navigator from Ivoclar, an old laser, and you can see the tissue retraction. And if I take an incisal view, you can actually see in the incisal view the tissue management here. And you can see the tissue management, the troughing that's occurred that allows a little bit of VPS. And perhaps on this area, I could have pushed the tissue back a little bit. Often we'll use a product like Exposil or one of these agents like Traxident to try and help push the tissue back in some cases if it's very deep. Here we did that in the old-fashioned case and got a very nice impression, put our provisionals on. And here we are with the post-operative result, which I think is a nice result. The tissue health looks fantastic. You can see interproximally the stippling that's occurred. And it's hard to differentiate the margins in this case from where the tooth begins and where the margin is. So, I wanted to show you this to say that you can go from a case like this to a case like this and do quality aesthetic dentistry using the diode as your management for tissue retraction in these indirect restorations. You see again before and after, and before and after. Hockey is a great sport here in Canada. We like hockey for many reasons. It's fast. It's got an edge to it. It's exciting. There's speed. There's aggression. And there's accidents. And we have many accidents like this particular case where a patient busted off a couple teeth and came in with, I guess, a dentist there had only one shade, A4, and put those on. And he asked me what kind of opportunities for more permanent restorations were available. So we again discussed the case and we talked about maybe lengthening the 2 laterals a little bit. It's hard to do that with a diode laser. I strongly encourage you to use an all-tissue laser, and I'll show you that in a little bit about how you do that. But here is the pre-op photographs, and what we did again was we sounded to bone, and we removed some soft tissue on the day of the preps. So I'm that comfortable with the case that I removed and recontoured, and the smile recontouring in this case, as you see here, on the day of the preps before I prepped the case. So we did not only soft tissue recontouring, but sounded to bone and relieved about 1 millimeter of bone underneath. When I talk about crown lengthening with the laser, some people get very anxious about troughing. But please remember, in CBCT studies, they show that 90% of patients have 1 millimeter or less of anterior facial bone on the upper maxillary central lateral incisors. So the opportunity to trough on those cases is very difficult using ideal settings and sounding to bone. I'm not advising you to take 4, 5, 6 millimeters off. Please flap. But just to do a minor amount of recontouring on the same day as your preps is something that can be routinely done. The preps are done. And at this point, I'm using the diode laser just to show you some of the video of the troughing here. And I'll just show you that the laser is a diode laser, and we're actually just trying to go 0.5 millimeter into the sulcus and distend the tissue off the margin so that there is room for the impression or room for your digital scanner to catch the margin. That's all you're trying to do. You're not trying to do a gingivectomy here. You're just trying to create a little space, a little moat, something similar to that first chord. And if you need to push the tissue back more, you can do so with one of these products like Expasil or Traxident. Here you are afterwards, and then I'll refine my preparation margins, refine the preps, trying to be as minimal as possible. And then we took our preps and took our impressions and put some provisionals on. Now, my provisionals are nowhere as nice as David's, we put the provisionals on. You can see here 2 weeks later that there's some marginal inflammation on the upper right lateral, tooth number 7 in the US, tooth number 1, 2 in the international system. So we take the preparations off, and you can see the inflammation in the 1, 2, and here are your veneers. We did some, at the patient's request, some tinting on the veneers to make them look and match more like his other teeth. And we've got some inflammation that we want to stop during the bonding process. You can see here, we've got the diode laser, or again, just using it to stop the oozing that's happening there so we can bond our restorations into place. So you'll see here, after utilizing the laser, the oozing is slowing down and stopping, and we can get our restorations in place. And this is on the day of cementation, so immediately post-operative. Patient returned. 2 weeks later, there's immediate post-operative, and 2 weeks later, you can see the tissue healing here from the veneers. So again, you know, we see routinely cases where Josh came in, rugby player. He was actually okay with his teeth, but his new girlfriend wasn't. So off he came to sit with us, and again, we decided to do, in this particular case, a couple of crowns and a couple of veneers. We did some recontouring with the diode laser on the day of the preparation. There are the preparations, 2 crowns, 2 veneers, diode laser for troughing, provisionals in place. Here's Josh before, here's Josh after, before and after. Retracted, and after. So this is immediately post-operatively, and Josh returned 2 weeks later. Here he is 2 weeks later. Josh is the modern day Flavio, and I asked him about his hair, and he said, "Oh, I've been growing it out for 4 years." He said, "You know your patient Jason?" I said, "Yeah." He said, "Jason and I are best friends." He said, "We've got to bet who's going to cut his hair first." And I said, "Oh." He said, "Yeah, so it's been 4 years ongoing." And he said, "Jason's just stays straight. Mine gets really curly." I said, "Oh, yeah, okay." So Josh ended up deciding eventually to get into the fire department, and got into the fire department. And what's the first thing they ask you to do is to cut your hair. So he comes out of the barber shop and he's had it cut at a place, and immediately his phone rings, FaceTime, and it's his friend Jason. Hey, Josh, you look like your hair is a little shorter. He said, yeah, Jace, I had to get it cut. He goes, guess I win the bet. So I said, oh my God, Josh, you must have felt horrible. How much was this bet for? He said, it was for a quarter. I said, only guys would not cut their hair for 4 years over a quarter. You know, I mean, it's just, he didn't want to lose a bet. But here's Josh's case, and you can see how the interproximal dark triangle is healed down in between the 8 and 9, and a nice result from where he was before. So when we talk, aesthetics, I mentioned a little bit about utilizing lasers for indirect and direct restorations, class 5s, tissue management interproximally. But one of the two things that we find all tissue lasers are really good for is closed flap crown lengthening, like the case I showed you on the previous case, and also for removing all porcelain restorations. And this has become really popular in dentistry, is the removal of all porcelain restorations using an all tissue laser. And I'm going to show you a case here, just a classic simple case. And in this particular case, this was actually a lady who came to see me. She was a dental assistant. And we talked about alternatives to improving her smile. And what she kept telling me is that her teeth on the right-hand side, teeth number 7 and 8, she felt they were too short. They're too short. They're too short. Her smile line is a high smile line, as you can see. It's not a low smile. And she said, is there anything you can do? I said, have you had a discussion with respect to perhaps grafting the lateral and canine? She said, yes, but I really don't want to do that. I prefer to lengthen the teeth on the right-hand side. So if you look at the golden proportion, indeed, tooth number 7 and to a greater degree, number 8, do look a little squared. It probably could be lengthened as opposed to making the other teeth a little shorter. So we discussed it at length, and what was decided was to use the all-tissue laser. And when you do this, it's 2 steps. The first part on the left is the gingivectomy portion, where I've put with a probe a little red dot with a periodontal probe as to where I would like to lengthen the tissue to. So I'm doing a gingivectomy parallel to the long axis of the tooth. And you can see I'm using, this is not a diode, this is an all-tissue laser, because after I do the gingivectomy, I'm going to recreate the biologic width, which was measured to be about 2.5 millimeters in her case. So once we've created an improved appearance, if we just left it like this with a diode laser, it will all spring back. She didn't want any restorations. We're just doing a crown lengthening in her case. And on the right-hand side, we've marked the tip, and you'll see the tip will be going up and down in a sewing fashion with water, and it will be going, I'm sounding to bone, and I'm just checking and going back and forth really from only line angle to line angle. I'm not going interproximally into the papilla. I'm just creating biologic width on the straight facial aspect of it until I get down to my 2.5 millimeters. So what does this look like post-operatively? Well, here she is immediately post-operative. You can see that I did tooth 7, 8, and 9 to lengthen them, to make them match more like the remaining teeth. And I look and I think, that looks pretty good. Is it going to stay? How's it going to be? Yes, you can flap this. Yes, you can remove interproximal bone. I'm just showing you what I did in this particular case. Here she is preoperatively. Here she is at 6 days healing. No painkillers, and a beautiful, beautiful result. Pre-op, 6-day healing. So in situations where you want to lengthen a millimeter and a half, closed flap crown lengthening can be something that can be an alternative. You have to be careful, and I'm not going to propose this to you for massive crown lengthening. If you want to do that, please feel free to raise a flap and do your traditional full flap thickness and full bone resection. I'm not going to tell you. This can be used for mild cases where you fracture a premolar cusp and you don't know, is that tooth salvageable or should you be placing an implant? How far subosseous is it? Can you get a margin on there? These are the kind of things where crown lengthening like this can be valuable. When you look at removal of all porcelain restoration, bonded restorations, this has been around now for a decade. This is not a new topic. I wrote about this topic in 2012 in Dentistry Today, and I wrote about laser removal of porcelain veneers. And this was based on some of the research from earlier years from Morford in 2011, Alfred Wyatt in 2009, and also this Turkish group in 2012, which were actually using them for debonding veneers, and earlier than that, actually debonding ceramic brackets. Excuse me. I wrote the article on laser removal of porcelain veneers. You can find that. So this is not a new topic. I also wrote about it in 2013, the Journal of Cosmetic Dentistry, and talked about using the erbium laser to remove porcelain bonded restorations in 60 seconds. I've done this topic at the American Academy of Aesthetic Dentistry, showing that this indeed can be done to remove all bonded porcelain veneers in under 60 seconds. Since that time, we're now using the laser at higher settings and for a little longer to remove crowns, and also using the laser for even zirconia crowns, not only EMAX, to remove them. And Jeff Kranska has done some nice work on using that. So it does not remove gold crowns. It does not remove porcelain fused to metal crowns. Those have to be cut off. But in all ceramic restorations, the laser can be used to remove these. So when you look at the literature, this is an article from 2019, and this Persian group looked at a comprehensive review, and they said removal of ceramic crowns and veneers from tooth surface can be successfully done with all-tissue erbium lasers in less time-consuming procedure and without any harm to the underlying dentin. And this is key, because when you remove it, the laser energy is transmitted through the ceramic and interacts with the cement, often leaving the cement behind on the tooth. So unlike where you're cutting these veneers off, and there's a risk when there's not a drastic change in color of cutting into the tooth, you can remove the veneers without removing any tooth structure. And I know David has patients coming from many areas because they want the veneers replaced without the iatrogenic damage that can occur when you have to cut them off. So this is a big problem. In this particular group article, they said that the erbium chromium lasers can successfully be used to efficiently debond feldspathic and lithium disilicate EMAX reinforced glass ceramic veneers. And during the veneer removal, no irritating temperature-wise was detected. And that is a key. You know, are you going to cook the pulp? This has been shown now with thermocouples in the pulp to not be the case. So this study, again, from this particular group in 2020, looked at pediatric crowns, zirconia crowns. And they said that the average time for removal of zirconia was in fact 3 minutes for permanent and 2 minutes for primary teeth. But when you look at the number of burrs and the cost for cutting through the zirconia restorations, we all know that this is an issue, and it is something we hate it when we look. And I'm glad I'm at 60 and not at 30, because all these zirconia restorations that are going to have to be replaced in 10 years are going to really be challenging for a lot of clinicians to cut them off. It is not a fun procedure. The temperature changes were 2.4 degrees Celsius for permanent and 3 degrees Celsius for primary teeth. Conclusions: you can use the all-tissue laser, safe, non-invasive, to remove prefabricated zirconia crowns. It's now been FDA approved. BioLase has FDA approval for laser-mediated ceramic restoration removal. So again, you can even market this if you wish, because they have approval both in the US and in Canada for utilizing their all-tissue lasers for this procedure. It's safe, quick, painless, and saves time, and often saves the veneer. So I've had situations where a patient has, we had one case, I'll show you a case in a second, but we had one case where a patient came in, the associate had been in the office, he used an opaque cement to rebond on the veneer. And of course, it was a central, and there was a dramatic difference in the color between the two centrals. So much so that the patient asked for the other veneers to be removed so that they could use the opaque cement to whiten the case. So I was able to get the veneer off, the single one, and use a clear cement that when the principal dentist came back, he bonded the veneer in with a clear cement and was able to reuse it. So again, it is something which can be used for many procedures. You know, it's the first laser company with FDA approval for this. So how does it work? Well, here's an I'll show you an animation in a second, but here's a case. This is not my case, but this is the kind of thing that I see, and David can appreciate this. This is a young lady who has something called body dysmorphic disorder. My wife is a medical esthetician, and she sees this a lot. Patients thinking that if they have a smile improve, that they're going to magically feel lighter, have more guys dating them, feel greater self-esteem. In this particular case, this lady was severely disappointed with the final result. I didn't think they were all that bad. She had 8 teeth done, but she was absolutely to the point of frantic trying to get me to remove these. These were minimal prep veneers. I think he prepped 1 tooth when he put these on, and she wanted them off. I took them off. So there you can see the post-operative result. It literally took me, I think, 20 minutes to get these 8 veneers off, and I did not damage the underlying tooth structure. So here she is with the 8 veneers off, and here are the veneers removed, and you can see they're in all cases not fractured. They were removed. I gave them to her in a box, and she brought them back to the dentist. So this is the kind of thing that we see. Can you imagine when you have to cut these off? Oh my gosh, the stress level. And she's stressed because she doesn't want you damaging her teeth. And if you look, you can see how we do this. So this is an animation. I did this many years ago. The laser energy from the all-tissue laser is transmitted through the veneer, and it interacts with the OH bond and the silane. They think that that's one of the mechanisms. It also, the cavitations and pulsing action may loosen it. But what happens is the energy is transmitted. So the thicker the veneer, the more difficult it takes. The thicker the crown, the longer it takes. And what happens when the laser energy goes through, it disrupts that, and it leaves the resin on the tooth a lot of times. So you'll find that you have to remove the resin afterwards because it's still on the tooth. Sometimes you have to mechanically remove this. I know David's got a nice video on YouTube on him using a scaler exactly this method to remove the veneers and get back to the underlying tooth structure. So here's a case. Lady fractured a lower incisor. The other incisor she wanted off because the color wasn't matching. So these were removed in 30 seconds with an old Hoya Combio, David. I put this in there just for old time's sake. This was the laser that David and I were using, a great laser, an Erbium laser. Never, ever gave us problems with the fiber or anything. It was really indestructible. But the company decided to get out of making lasers. And we used the laser for 30 seconds in about 4 to 6 watts. Transmits through these Emax restorations. And then what we're able to do is often get a scaler underneath. Sometimes they'll slide off, and sometimes you're trying to find an edge, and on the 4th try right here, pop, it's gone. I said, where is it? Flew over her shoulder, and there you see the prep underneath. And here's the other one, boom, off it comes. There's the veneer. You can see the inside surface of the veneer with some of the cement, but a lot of times the cement is left on the tooth structure. We actually prep these, I believe, for full restorations. There's provisionals and there's the final restorations on the right. Here's another case. A patient came in, wanted her veneers that were 15 years old removed. And the tooth number 7 was actually a crown. And when I got it off, it was very, very tiny, that tooth. So I was really concerned with it. It was right next to the pulp. And I did the final restorations. Here's before on the left, after on the right. You can see the final restoration. I was really quite pleased with it. And sure enough, 3 months later, she phones me crying on a Sunday, as is always the case. My tooth, I can't sleep. I never slept all night. Tooth 1, 2, the upper right lateral incisor has gone non-vital. So I don't know how you feel about drilling through these teeth, but so often you drill through and do your endoaxis on the lingual of these teeth. They fracture, the color never matches, or worse yet, it doesn't fracture, and the patient comes back 6 months later with a crown that has come unglued in a sandwich bag. And nothing good ever comes in a sandwich bag. You never get anything good in a sandwich bag. If the patient comes in, always you look in and all the coronal tooth structure is shattered off, and now you're looking at an implant. All because you couldn't get that veneer or crown off. In her case, we were able to get the ceramic crown off, as you see in the middle. There's a tiny tooth structure. There's the endo access. Look how small I was able to keep it with the with traditional means. I was able to, in fact, put a little post in and use the same crown and cement it back into place. Same color, same one-day treatment, get the crown off, cement it back in. A lifesaver, truly a lifesaver in a case like this. So we were able to go, and this case has been ongoing now. It's, I think, 8 years old. It truly is a lifesaver, the Erbium laser, for these kind of procedures. Finally, I'll show you a posterior case. Before zirconia was around, we often would do EMAX in the second molar region. And I don't know if those of you who have done that will find that it's not uncommon that, like porcelain bonded to metal restorations, the porcelain is always fracturing. It seems like its second molars are not great candidates for EMAX, and so zirconia is better back there. With the translucency that's improved now in zirconia crowns, I think they're better. But this was an EMAX crown. And we used the laser on it. Here's nice light again. I used 6 watts on it. I'm not going to show you the whole procedure. I'll just show you that we often will use the laser on the occlusal aspect, on the buccal aspect for about a minute to a minute 20 seconds at the maximum each. You want a couple key tips. One, you want a brand new tip. You don't want to use an older tip because you want the energy to be fully transmitted. You want to be close to the veneer and, if possible, parallel to the lung axis. So on the facial, you want to go at 90 degrees. And often I'll use a scaler. I'll create a notch underneath there on zirconia crowns, and I'll often use a CoronaFlex to pop this off. And you got to be careful because you don't want all your tooth structure, but here you go. You step on it, the pedal, and pop, off it comes. And I can remove these often in under a minute or 2 minutes without having to cut them off. And it makes it so much easier to re-prep the tooth very quickly, trough with the laser, and have there's a restoration, and have a new zirconia crown made. So really, this can be a tremendous benefit for you, is the removal of all bonded restorations. So in the first part here, in the first 45, 50 minutes, I want to hammer home a couple points. One, various lasers are available in dentistry today, and 2 most common ones are the all-tissue Erbium lasers and the diodes. Lasers can be used for tissue management, both in indirect restorations, like tissue management interproximally around your crowns, around your veneers for troughing, or for impressions, be it digital or regular impressions. And they can be used for class 5s, and they can be used for direct tissue management in composite resins. And all tissue lasers can be used to remove porcelain bonded restorations. They can be used for minor crown lengthening. I won't tell you to do major, but they can be used to do minor crown lengthening on the same day, and smile recontouring on the same day as your preparations are done. So that's the end of part 1. I don't know, David, if there is apropos questions that you want to ask, 1 or 2 questions before I begin part 2, which is the laser or the implants, or whether you just want me to continue.
Hey, Glenn, can you hear me? I think you're muted.
David's probably out surfing, so.
I think you muted your speakers.
Oh, maybe I have to turn it up. Can you hear me, David?
I can hear you. I don't think you can hear me. Can you hear me?
Yeah, I can hear you now.
Oh, okay. I was asking you questions earlier.
Oh, I'm sorry. You know what? I had the sound off, and it was because I didn't want the laser making so much noise. So okay. I apologize. I didn't hear you.
Oh, that's all right. I asked you a million questions. You didn't answer it. No, I'm just kidding. One thing that you didn't really address, and there's been some good questions, but I think I answered them. So, you know, the whole 980, 810 thing. So for those who don't have diodes, different manufacturers, they'll either say they have an 810 nanometer or a 980. And if they sell a 980, they're going to say 980 is better. If they sell an 810, they're going to say the 810. I have both. I notice no difference at all in hemostasis, postoperative pain. What's your thoughts on that?
Yeah, I agree. You know, I'm fond of saying a diode is a diode is a diode, and they all work well. I have used 810, 940, 980, and 1060. And I haven't noticed a difference in any of them. 1064. I have not noticed a difference in any of them with respect to the clinical work. They all work well. I will say this, for photobiomodulation, there is some evidence that suggests an 810. The closer you are to a aiming beam, the better it might be. So an 810 might be slightly better than a 940 or 980, but is it clinically significant? I'm not sure. There are some people who say that 980s are better absorbed in water, and hence they're going to be better for perio. And then the 810s will say, well, they're cutting better, and because they're not absorbed in water, so surgically they're better. I would tell you that if you have a diode, don't go buy a new one just because you think that the new wavelength is going to be so much better. It's not. And if you have one, use it. How's that?
Yeah, I totally agree with you on that. Yeah, and everything you talked about, I totally agree with you on the crown length. I probably do it once a day. And, you know,
Okay.
the thing that you did stress is, the nice thing about it is, you know, you're going through the sulcus. So it's, you know, you're taking parallel to the root. The people didn't get that. You know, you're removing the tissue first, totally violating biological width, and then going in and laying it parallel to the roots and remove bone. And what's amazing, I mean, I've done cases where I've removed as much as 25 millimeters of bone. If I do, you know, 10 veneers, and I'm bringing everything up.
Wow.
There's no post-operative pain. I mean, zero. The only post-operative pain the patient has are my injection sites. And you're right, we prep and take impressions the same day, and it, you know, closed flap osseous reduction. I mean, you can do crown lengthening, and like you said, patient, especially on the lingual, patient breaks lingual cusp of a premole, and you're thinking, I don't know if that's below the bone or not. You can go in there and you can drop the bone a little bit and still impress the same day. So,
and
awesome.
if you use I'll say low to moderate settings, you actually have a tactile feel, because what's happening, the laser energy is interacting with the bone about 1 millimeter away. So you actually can stop, and you can use it almost as a probe to check to see if you're getting a trough, and if you have too high settings, then you'll pit the bone, because we've done it on pig shells. I don't know how many times. And with low conservative settings, you can actually feel that the bone is just melting away very slowly. And so I always caution, because I know that, you know, and understandably so, periodontists, they've been geared for full flap surgery, and really that is the gold standard. I'm not going to tell you it's not the gold standard. It is the gold standard. And again, if there's any periodontists on here, of course, I don't want to say that it's not the gold standard. It is the gold standard. But if the patients are given a choice, they will often tell you that they really preferred, you know, not having the sutures, not having the swelling, not having the discomfort there, not having that bruising that's possible with minor osseous recontouring with the laser. So I use it all the time, posterior, anterior, and again, I pick my battles. I'm not doing as much as you, because I'm not as brave as you, but I will use it all the time for 1.5, 2 millimeters of selective osseous recontouring through the sulcus, as you said.
So let me ask you too. So I'm using, for the setting, for those that might have a Waterlays, I'm using 195/25. What are you using now for your settings to remove?
So you're using 195 millijoules and 25. So that's roughly, you're using roughly 4 watts, 4 or 5 watts. Often I'll try and use a high repetition rate, meaning a high number of pulses per second. So let's say 30, 40, 50 pulses per second. And each pulse I'll often use in the 50 to 80 millijoules. So often if you're looking at, say, 50 millijoules and 30 pulses per second, that's 1.5 to 2 watts. And that's what I like to use, because it's slower. And I use it in a sewing needle fashion, up and down, up and down, up and down, you know, going underneath.
Yeah,
and
are you talking about osseous? I'm talking about removal of crowns.
Oh, yeah, removal of, so osseous is 1.5 to 2 watts. Removal of veneers, 4 watts. Removal of zirconia crowns, up to 6 watts. I don't like to use more than 6 watts with the BioLase, because it's not great for the fiber long term when you're using high power settings. So often I'll use 6 watts. If I have to use more, I'm a little concerned that it's going to have a long-term effect on the fiber.
Yeah. I tell you about a cool case I had a couple months ago. I had a dentist call me from LA, which for those that aren't, it's 2 hours from me. I'm in San Diego, right? And he says, Franek, I had this patient from Japan that had a 3-inch bridge that one of the units debonded, and I can't get it off. And so he sent me a photo, and it was like one of those, for those that have seen some Asian master ceramics, it was the most beautiful ceramics I've ever seen in my life. So I said, send her on down. I'll stay a little late. So she drove down, and sure enough, it was zirconia. And like I said, it was just an amazing, I mean, the artistry of the ceramics was absolutely amazing. So I told her, I said, I might break it. You know, I was trying to get it off, but I'll do my best. And it took me about 2 minutes, because on the crowns, you know, you have to go facial and lingual and try to go interproximally. We were able to pop that off and re-cement it. And when you get an opportunity to do something like that, like you just said, and re-cement this beautiful ceramic, I mean, it's such a gift to our patients, and it really is amazing. It really is.
Yeah,
amazing.
It can be a lifesaver.
Oh, especially with our Emacs. For those that have cut off Emacs, you know, I've had my share of cutting off 10 Emacs crowns. You know, we call it the new 10 diamond procedure. You know, it's 2 hours just to get the old ceramic off. And, you know, to be able to take the majority at least off with the laser, I mean, it not only does it save time, but it saves diamonds, but it's more comfortable for the patient. You know,
yeah, there's a big pucker factor when you're cutting those off. I mean, it's stressful, because as a patient stressed, you're stressed. You know that if you take off more enamel, you may not be able to do another veneer. You might be doing a crown, or why did my other veneers last so long and they never debonded? And 2 of the ones that you've just done have debonded within the first 3 months because you were into dentin, because you couldn't see, because the color was not that much different than the underlying tooth structure. It's difficult, man. And it's nice when you can say to the patient, hey, I'm going to get the veneers off and then we'll see what's underneath there. I'm not going to be cutting any tooth. And it's a lot, the sound of the drill cutting these things off is not fun, believe me. So, you know, it's a lot nicer if you can just pop them off.
Okay, good.
So why don't we move forward into the next section, so I don't keep you up all night, especially for those, I'm on the West Coast, but for those of you, you know, elsewhere, I don't want you having breakfast with me. So why don't we move on, David? And I'll leave the sound on except for videos.
Oh, perfect.
And then I apologize profusely for me missing the questions, and I'm happy to stay at the end to answer any of the questions that I didn't get to. If something comes up, I'm happy to stay. I just want to make sure that you get your CE and that I'm not keeping you here all night. So in the second part, we're going to talk a little bit about lasers in implant dentistry. And what I'm going to do is I'm going to categorize laser usage in implant therapy by the stage. And I'll tell you why and why we do that. And then I'll show you some laser clinical cases. And we'll talk about the role of lasers. And there's some quite exciting things that are coming out. And we'll talk a little bit about low-level laser therapy and also the role of lasers in peri-implantitis. And we'll talk about that as well. George Romanos is on the East Coast, and he wrote an article in 2013 categorizing lasers in implant dentistry. And he wrote about the role in peri-implantitis, soft tissue surgery, actually using an all-tissue laser to do the osteotomy, accelerating osseointegration, improvements in wound healing and hemostasis, and also using photodynamic therapy around implants. It was a great article, but it was all over the map, and it really wasn't, it didn't categorize. And what I did is I wrote in 2015 an article in Dentistry Today on actually looking at utilizing lasers by the stage of the procedure. There were 2 parts to this. You can find it if you want in Dentistry Today. And there was 2 parts. And really what it did, it looked at categorizing laser usage in implant therapy by the stage of the procedure. So in stage procedures, for instance, prior to placement of the lasers, where I did one today, took out a really nasty root canal treated teeth. And, you know, I have a friend of mine who's an implant specialist, and he says, oh, the root canal teeth are just a placeholder for the implant. And unfortunately, you know, we see that I tell my patients, you're having a root canal done, and this will extend the lifetime of the tooth, but I don't know by how long. And even in my wife's case, she had a lower second molar that was done, lasted 20 years, and then vertically fractured. And we had to put an implant in there. And so prior to placement, we see a lot of fractured teeth in patients who are keeping their teeth until their 80s and 90s, and the implants are failing, or the root canals are failing. And instead of a bridge, we're looking at doing a single tooth implant in there. So lasers, all lasers will be antibacterial. So they disinfect the extraction site, and they're all wonderful for degranulating the extraction sockets. I don't use lasers for lateral windows, but they can be used. I don't like them because they're not specific for hard tissue only. And like a piezo, they can't cut soft tissue. And so you have to be really careful with this Schneiderian membrane, but there are articles out there on utilizing lasers, all tissue lasers for lateral sinus lifts. During implant placement, they can be used for the actual flap. It's amazing the visibility you have when you do this. They can be used for an laser-assisted osteotomy. I don't do that because I find that they're, again, not selective for osteotomies, for bone only, and you don't get a regular pattern. But they can be used for decortication in GBR, and I will show you that, and there's some benefits for that. They can be used for leveling both bone and soft tissue during implant placement. And so you have a little bit of bone in one area, you can quickly use the laser to remove it. In cases where I'm going back at second stage, and often I'll find that there's bone over top of the fixture, very easy to pull the laser out and remove it. And one of the greatest things is low-level laser therapy. And I'm going to show you that. I'm going to talk a little bit about how it works, and it is a godsend. It really is. And it used to be that people said, oh, that's all smoke and mirrors. But every single article, if you don't believe me, look up low-level laser therapy implants, low-level laser therapy extractions, low-level laser therapy wound healing. And every single article shows benefits in doing this. And it's simple, quick, and you can use your existing diodes. Uncovery, there's uncovery, like I showed you in the first case, you can uncover your implants rapidly and do the impressions the same day, saving the patient another appointment. And we do this all the time. Do a little uncovery, manhole uncovery, and save the patient a second appointment. During prosthetics, if you have tissue in the way, you can uncover them. And after prosthetics, we see growing nature of peri-implantitis. And I'll tell you that lasers can be used for degranulating, disinfection of the implant, for removal of Ti-unite, to get back to the titanium fixture. It's really can be a godsend. So I'll talk a little bit about this and some of the benefits of using an all-tissue laser for that. Due to time, I'm not going to go through all this. I'm going to give you a little viewpoint of some of the things where I use it routinely, and we'll cover these areas in the time that we have remaining, and hopefully this will give you some understanding of some of the excitement that's around for lasers in implants. Prior to placement, Ed Cusick wrote this article in 2011, and what he did was he looked at immediate implant placement and in infected sites, and how to remove the bacteria. And what he found is that he did an extraction, took a swab, then used the laser inside the extraction socket and took another swab. And what he found was that there was a significant decrease in bacterial counts after the laser was used. And there were no traces of virulent bacteria with laser treatment. So even in these cases where you want to do an immediate, save the patient 3 months, but you've got a lot of soft tissue, a lot of infection, a lot of bacteria in there, and you're worried about it, the laser can be really advantageous for not only removing bacteria, but removing granulation tissue within there. This particular study, again, looked at it. Giovanni Olivi is a well-known laser dentist in Italy, and he found that utilizing the implants prior to implant placement for disinfection led to less postoperative pain, bleeding, or swelling because of low-level laser therapy, an increase in bone density that follows up CBCT, and it was significantly higher in the laser than the control group, meaning that the bone density and early healing was higher in the laser group. And he concluded that it's a safe and effective method to improve post-extraction bone healing. So not only are you getting improvements in disinfecting and degranulating, but you actually get an improvement in the bone healing by utilizing the laser within the extraction socket. So when you look at socket preservation, in a case like this, we have a lower second molar with a gold onlay on it. And, you know, in today's COVID world, I don't know how many of you are seeing more and more cracked teeth, but we see it's a pandemic right now. And this is an old case pre-COVID, but my gosh, I see a lot of cracked teeth. And it's unbelievable how many times the distal margin of lower second molar has a crack that goes all the way down. And that was the case here. Patient came in, 12 millimeter pocket on the straight distal that you see here on the gold crown. And we were able to get that tooth out. And through the microscope, it's kind of cool. When you look at the tooth, here's the socket and here's the tooth. And if I press play, you'll see at the different magnifications how clear the crack becomes. Here it is as we rotate the tooth, 2 millimeter or 2 power, 3 power. Watch the crack progress all the way down from the distal margin, 8 power. Look at the crack there, all the way down, right to the near the apex, and you can see these cracks. You can see them with methylene blue, but that tooth is toast, and that's why the bone loss was there. And so you've got that socket that you saw, and now you want to remove the granulation tissue and disinfect. So the laser is really cool because you can peel the soft tissue off the bone. So that's what I'm doing here. I'm actually peeling the soft tissue. I don't know how many of you like threading these, but it's not easy. You can take a burr in there, a football-shaped burr, but you can see how quickly I was able to get that soft tissue to peel off there. And it's amazing how you can clean out the socket and remove the granulation tissue, and how much granulation tissue is existing in some of these cases. In order to bone to give socket preservation bone graft, you need to get a clean site. Afterwards, we use a radially firing tip, and this is really cool. We use this, and we get this photoacoustic streaming. Some of you may notice that the epithelium on the buccal wall is been de-epithelialized to slow down the ingrowth into the site. But watch this photoacoustic streaming in slow motion here. It's bubbling, and this is what's causing the cell wall lysis, and this is what kills the bacteria. So it's like an endo with the cavitation that occurs from some of the photoacoustic streaming devices. This is the exact same with the laser, and this is what disinfects the socket. So you remove the granulation tissue, you pack your bone in. In this case, I used a resorbable membrane and sutured it down, and there's the socket immediately afterwards. Patient comes back 3 months later. In this case, what we did is we actually used a diode laser on the same day of the surgery for the socket preservation, because they are showing that utilizing a diode laser for low-level laser therapy, or PBM, it's called photobiomodulation, can improve osteoproliferation and osteoinduction for early bone formation. That's what all of you showed as well. Wavelengths higher than 900 or wavelengths higher than 800 nanometers and irradiation longer than 3 applications resulted in better bone. But typically I'll do this on the day of the surgery for a couple of reasons. One, it significantly improves wound healing, and it significantly decreases pain. And that's been shown in many, many cases. And I'll talk about why in a minute. But we use this a lot in our extraction sites, in wisdom teeth, in any big flap surgeries. We use it a lot to try and decrease the postoperative discomfort. Because you want to rely less on antibiotics, because 50% of the patients in Europe are now resistant to amoxicillin. So we want to rely less on antibiotics. And secondly, we want to try and help those patients rely less on painkillers. You know, with the fentanyl crisis that's going on, anything that we can do to reduce heavy-duty painkillers by utilizing anti-inflammatories with the laser and ice, you know, maybe we can get away without using more powerful painkillers. More research on exact parameters is needed, but what I can tell you is that all the studies show it can be used. So in this case that I talked about, the patient came back 3 months later, and this is in the old days before guided surgery. We did this case actually flapless, but we punched a hole through a Essex retainer. I actually used the laser to create a little site, and then I removed the tissue, not with a tissue punch, but with the laser, as you see here. We did the osteotomy through this. This is before guided. And here's the implant in place. We put a healing abutment on, and you can see the healing abutment here. And if I had done it guided, I think I would have been closer to the tooth. Patient came back, and you can see the removal of the healing abutment and the nice healthy appearance of the soft tissue. A impression was done. You can see the impression here. And again, I mean, I'm not going to tell you that it's a perfect placement because it was a little far distal. And now this is resolved with all the guided surgeries where we can precisely place these in situations with big ridges like this in a very easy and quick fashion through guided surgery. There's a final result and the nice appearance on a case where we had staged. So again, lasers can be used prior to implant placement where you want to stage it. We can also use lasers in GBR, and I use them instead of burrs for decortication, and there's a reason why I do use them. Kessler and his group in 2011 showed that erbium laser radiation seems to stimulate the secretion of PDGF in osteotomy sites in a rat model. And what they concluded that compared to birth, the radiation by the lasers actually enhanced and improved the healing of the osteotomy sites. In this more recent study from the Japanese group, Akira Aoki is very, very well known for his research in using all-tissue lasers. And he found that the laser selectively and effectively ablated bone without major thermal damage. So you can use this without heat generation. And he said it might accelerate early new bone growth, as I've shown you, with advantageous surface changes and cellular responses for wound healing compared to burr drilling. So again, the early bone formation is better in those cases where you're using the laser than it was using a burr. So here's a case where a patient wanted this tooth removed. It was periodontally involved. This is the lower right second molar, I believe, and it's leaning over. And this lower right second molar was extracted. And you can see the extraction here. And then we flap the case, and we're going to put 2 implants. One in the second premolar site and one in the mesial root of the second molar to give 2 implants, one for a second premolar and one acting as a first molar. So you can see here the flap, and you can see how narrow the ridge is in the second premolar site. So again, what we did in this case was again non-guided, but we put the posterior tooth in the mesial root, vertically up in a much better fashion, and then we ridge split the bone, and then had a ridge split and put a smaller implant, a 4mm implant in the anterior region. Now, a lot of times versa-burrs are around, and they can be utilized in a counterclockwise rotation to expand your bone, and you're left with a situation where you got the implant in, but there's very narrow remaining buccal plate. So in this case, we'll actually graft do some GBR on the site, but we would like to get some bleeding to encourage the release of PDGF. So we got our 2 implants in, but it's very narrow in this area right here. Very, very narrow and very thin. So what we're going to do is we're going to actually use the erbium laser, and we're going to decorticate. And you'll see how quickly this is. I'm not worried about the burr touching the implant or causing any heat on the implant, because there's water coming off the laser. And we just make little 1mm spots in the cortical bone into the medullary space, and you get a release of your PDGF. And you'll see afterwards, after I use this, I can very quickly put 8 to 10 little precise spots here. And immediately afterwards, you can see here these precise spots that we've put in so that we have the release of the PDGF and our growth factors. And then we graft the bone over top, put a resorbable membrane, in this case, tacked it over, and had full closure with Gore-Tex sutures. Patient came back in 3 months, and we're going to uncover. And what's kind of cool, actually, as you can see, there's actually bone formation over top of the fixture. And I'm using the laser in this case to remove some of the bone overlying the fixture, because there's so much bone growth over top. I had to remove the bone over top of the cover screw. Immediately thereafter, you can see the bone formation around the fixtures, the healing abutments. This is an older case, probably do it differently now, but we did a crown on the anterior, and she wanted the 2 back ones, no screw holes. She wanted them cemented, so we put stock abutments in, and we had them glued over in a pearly white shade that David would be proud of. So you can see the final result there, and enough attached tissue for the case. So I talked to you a little bit earlier about utilizing a diode laser for low-level laser therapy, and I really want to strongly encourage you to look into this. This is something that can be a game changer for you, and if you have a diode laser, you can utilize this. And often, I don't put a tip in. I just use a barrier over top of the handpiece so no debris gets onto the laser itself. but we just use a barrier over top if it's a big spot size, and I just use it for a minute. There are lasers that have the built-in settings over top of them. I know I'm in Canada, so I'm not sure which lasers in the US have that, but I know, for instance, Zolar laser has it built in, and I know that the Epic X, I think, has it built in as well, the low-level laser therapy, photobiomodulation. So how does this work? When can it be used and why? Well, what happens is in a situation like this, the near infrared light that is coming in is absorbed in the cell walls, in the cells by the mitochondria. So the mitochondria within the cells absorb the near infrared light, and it releases three products: nitric oxide, NO, reactive oxygen species, ROS, and ATP. And it's the reactive oxygen species and the ATP that cause something called gene transcription. And what gene transcription is really the cell goes into hyperdrive. It starts to produce more growth factor. It produces an increase in cell proliferation. There's an increase in cell motility and an increase in extracellular matrix deposition. So those four things lead to really improvements in three areas. On the top, you can see on the right-hand side, you get an improvement in wound healing, tissue repair, and tissue death. So we use this a lot for patients nowadays who are diabetics or patients who are on medications that perhaps are going to slow down our wound healing. It's fantastic for that. We even have some oral cancer agencies utilizing this for the tremendous improvements it does for ulcerations with chemotherapy and on patients who get massive wounds. So a lot of the oral cancer treatment centers are utilizing photobiomodulation for wound healing and ulcerations in compromised patients. It also, if used for a little bit longer period of time, can decrease pain, can decrease inflammation and edema. So for things like extraction sites, nothing better than the patient saying, hey, I had 2 wisdom teeth out on the other side, and oh my God, was that ever sore compared to what you did? I don't know what you are, doc, but you're amazing. And those kind of little touches, we don't charge the patient anything for it. We just use it for a minute afterwards on the site, and usually at half a watt. Now, there are built-in settings for some of the lasers, but I'm going to tell you, too much energy will actually overheat the tissue. Too little won't do much. So a safe setting is half a watt for 40 seconds for wound healing, half a watt for 40 seconds for wound healing. And if you want pain relief, you need to use it a little longer. So I tell patients, use it for a minute to 80 seconds. Is it exact? No. If you want exact settings, you need to go and look at lasers that are intended exactly for low-level laser therapy. Things like TOR, T-H-O-R lasers. James Carroll's done a tremendous amount of research in this area. Excellent lasers, have all the built-in settings. They're expensive. So if you're going to go, if you really want to do this, you want to start looking at a low-level laser therapy. I just use my diode. I use a bleaching wand sometimes for TMJ, for instance. It can be fantastic for TMJ for long procedures where the patient's open, like endo or all on 4, cases where they're propped open and they have TMJ situations. We use this for 2 minutes each side with a bleaching wand on the TMJ, and usually at 1 watt because the bleaching wand has a larger spot size. Otherwise, we just cover the barrier, no tip. Just put a barrier on top of the handpiece and use it for 40 to 80 seconds. James Carroll is an awesome guy, done a lot of research on this, written an 83-page review in 2014. It said the benefits of low-level laser therapy include improved healing, decreased inflammation, and decreased pain. Thus, it could have considerable potential for use in oral tissues. And since that time, many, many well-designed studies are showing that lasers can be used to help you with your surgical cases. There's 4 common clinical targets, and a lot of these slides are from Jerry Ross, who's an expert in Canada on low-level laser therapy. And the first site is the area of injury, so an extraction socket, for instance, to promote healing and to reduce pain. The second site is lymph nodes. So some people will actually use this on the lymph nodes first to help clear the lymph nodes and improve the ability of the lymph nodes to deal with the edema and the inflammation. The third site is on nerves. So people have used it after paresthesia cases. I've used it in Bell's palsy cases, even long-term Bell's palsy cases.
I've used it effectively on lingual paresthesias induced by your injections. So we use it over the extraction site, or sorry, over the injection site and on the areas of the tongue that are affected. Because the patients are super angry that you have damaged their tongue. When is this going to come back? I don't know. I'm just going to map out the area. I'm going to give you some corticosteroids, and we'll see you in a month and see how you're doing. That doesn't cut it. So we do this for free. We usually get them in 3 times a week, every second day, say a Monday, Wednesday, Friday. It takes me 5 minutes to do. I don't charge them. And it's a big practice builder to try and save it. And it does happen. I would be surprised if everybody in this audience hasn't had a situation where a patient has called them and said, my tongue's still numb, and they're not happy. And the final area is trigger points. So things like TMJ, we use it on their TMJ, and it's immediate. They say to me afterwards, oh my God, it feels better. My jaw feels better. Yeah, it's not so sore when I'm moving it. So it can be a real big lifesaver in your practice. And many of you have diodes that you're not using. Put a barrier on the handpiece. Use your bleaching wand if you have one, and use it in these cases. If you're really concerned about dosages, I forgot to put this volume up here. Maybe if there's any questions. If you're concerned about dosages, I typically use half a watt for 40 to 80 seconds. Okay. 810 are the best. 940 is good. 980 is good. Don't worry too much about it. If you have a diode, use it. Acute injuries like an extraction site or a flap surgery benefit from 1 to 2 sessions. Chronic things like Bell's palsy or lingual paresthesia require more sessions, like 3 sessions per week, for a maximum of 2 to 3 weeks, and then it levels off. I have seen almost it. I don't know how many times we've done this. The patient will say to me as I'm doing it, oh my God, stop. I say, what's going on? My tongue is tingling while you're doing that, right where it feels numb. It's tingling. It's almost like there's activity going on. And people look at me and go, yeah, you're crazy. But I'm telling you, it's weird how the patient will say to me, yeah, you can look online. If you look at some of the people that have used this for Bell's palsy, and they use it for 15 minutes for Bell's palsy case with a bleaching wand, and they ask the patient the same questions. So side by side, there's a noticeable improvement with lack of the damage to the muscles, and how the muscles are able to move better immediately thereafter. So, it can be used. When you look at why is it that 40 seconds will work for pain relief and 40 seconds will work for wound healing and 80 seconds will work for pain relief? It's something called the Arndt-Schultz curve, and this is on your right-hand side. Early on, as you use the energy is utilized in the cells, it's activated, and what happens is you get improved wound healing. And if you use it for longer or higher energy, you then get decreases in inflammation and pain control. So what they call the early stage biostimulation, which is wound healing and using lower doses. What they call the later stage is called bioinhibition. And bioinhibition is decreases in inflammation and pain control. So again, when you want to do wound healing and you're not so worried about pain control, you can use it for 40 seconds or so at half a watt. And if you want to use it for pain control, then maybe use it for a little bit longer, 80 seconds at half a watt, and then see how the patient does. And you might surprise yourself. If you really want to check to see if it's the case, those of you doing 4 1/3 molars, do one side only. Don't tell the patient. Get them back. Say, hey, how you doing? Oh, I don't know what's wrong, but I don't know why. The left side hurts me more than the right. And he'll say, yeah, you think to yourself, you do that a couple of times, you realize that the right side is the one that you use laser on. And I know it's hard to believe for many people, but I'm telling you, it does work. So here's a case, simple case of a case that we used it for. This is a patient, again, an older case. It was one of my former associates, and he had an endo and he had an apico done on it. And he came in one day, he said, I got some swelling. He said, I don't know what's going on. And I looked, and his mesiobuccal root was fractured vertically in half. And you can see this is not an easy case. The amount of bone loss that's there, it's scary. CBCT shows, excuse me, the mesial root broken in half. You can see it on the CBCT right here. It's vertically fractured right in half. And here is our fun extraction. And I love these where, you have 20, 25 pieces, and the microscope can be really helpful for getting these little pieces out and ensuring that even after sectioning that you've got the whole thing out. if you look in the collage here in the middle, you can see that after I got the whole tooth out, there was very little bone left, from the surgical extraction. And we then packed bone in, put a non-resorbable membrane, in this case PTFE, cortex membrane, cytoplast over top. And there in the bottom row, you can see the diode laser without a tip, with a barrier over top. I'm using it for 80 seconds, and there is my bone grafting on the day of. Okay, so 80 seconds to control swelling and to control inflammation. Patient came back 3 months later, and we have a situation here where we have only about 6 millimeters of height. So we did a crustal approach to the sinus in this case. And here that is, we did a flap in this older case. And if I had to do it again now with guided, you will be much better in your osteotomy. It won't drift on you like it did a little bit in this case. This is, for those of you using Hyosin, this is their Hyosin case. What it does is they have a saline solution they pump in, and you can lift the sinus lining that you're seeing here, the Schneiderian membrane, through the crest. And we put a little bit of bone and put the fixture in. You can see the fixture here. And then we're using the laser on the bottom right for 80 seconds again to try and decrease the swelling and discomfort on that upper right osteotomy site. This is a cool shot through the microscope. You can see the Schneiderian membrane is intact. This is the view we get when we use a microscope for these procedures. It's pretty incredible to see the vascularity of the membrane, to know right away whether it's moving up and down, and to be able to control your procedure so precisely when using the microscope itself. So again, it drifted. If I had to be picky, I can say that for sure I got a lift here, and perhaps I'd like to have this in a better position. Here we are, post-operative CBCT, and you can see the implant there. You can see the approach to the sinus. You can see there the lateral view and the sinus lining. I don't routinely do post-operative CBCTs, but I did in this case to check to make sure that everything was good. And here we are again, utilizing the laser with a barrier on it over the site. And also, because he was open for quite a while, we use it with a bleaching wand over the TMJ, 2 minutes. Just over the TMJ, have them open and close slowly. And the patient will say, it's amazing how much better my jaw feels just after the 2 minutes of you utilizing it on both sides. Don't use it on one side only. I've heard people having vertigo after this. I'm not sure, but I'm just telling you, use it on both sides. We use it for gaggers sometimes. There's a P6 acupressure point on the inside of your wrist, and you can utilize it on the patient's inside of the wrist, both sides, to try and decrease gagging. We utilize it for improved wound healing in diabetics. There's a lot of different reasons for utilizing it. Here's the 4-year follow-up, so you can see that the implant's still in place, and it looks good. Would I prefer to have a better position? Yeah, for sure. But again, going from that case where it was very, very little bone formation there, and how bad it was after the extraction, I feel pretty proud that we still have that implant in there. We're able to get some bone in the area. So lasers have been used for, studies show, for reducing morbidity and pain around third molar surgeries, effective for tissue repair and pain relief. It's effective for higher initial mineralized tissue volume and for greater degree of osseointegration, bone to implant contact. And also it induces higher degree of osseointegration, which was associated with a greater expression of bone morphogenic protein number 2 and OCN. So again, it's releasing greater growth factors, and you're finding that you're getting improved wound healing. So let's move on into what a lot of people use their laser for, is tissue around implants and uncovering. I wrote an article in, I think 2011 on this, but more recent articles have compared soft tissue wound healing utilizing a diode laser. This is an 810 nanometer for conventional scalpel technique for second stage implant surgery. And sure, we all like to do one stage, but unfortunately we do have cases which are spinners, or where perhaps you're concerned. As Dennis Charnow says, one miracle at a time, and sometimes it's best to stage these cases. You can minimize your surgical trauma, as I showed you earlier, right at the very beginning, reduce the amount of anesthesia, improve your visibility, and eliminate postoperative discomfort by utilizing either a diode or in many cases, an all-tissue laser. Don't use an electrosurge. I'll repeat that. Don't use an electrosurge. Massey, in his study back in 2004, actually, in this article, looked at 20 failing implant cases that he could not remove the implants with 35 Newton centimeters or less and counter-rotating them. So what he did, he used a 3-second application of the electrosurge, no anesthetic. Just took the superstructure off, touched the implant for 3 seconds, no anesthetic, and then put the superstructure on. And in all 20 cases, all the implants were removed with a reverse torque of less than 35 Newton centimeters 2 weeks later. He said the bone necrosis was minimal around the implants, but he actually suggested monopolar electrosurge unit as a reliable, quick, easy, and safe method for fixture removal. So I'm telling you, please don't use your electrosurge around your implants unless you want to have situations where you have thermal explantation. So comparing that to a laser, you can either do a manhole, I call it, so the front one, the manhole uncovery, or you can do a trapdoor uncovery. So which would you use for which? Well, in the posterior region, I often will use the manhole because I might have enough keratinized tissue. And if I do, I'll use it because you need to have enough attached keratinized tissue in this area. And if you do, you can use the laser to remove, not move, but remove the tissue. Remember, you're removing it. It's no longer going to be there. If you want to save it, don't do a manhole. Do a trap door. Here's a manhole being done with the laser. I'll go over this quickly because I showed you earlier this in the first case from yesterday, uncovering an implant which had lost its healing abutment. But these are quick, and if you have bone over top of it, as I did in this case, there's a bone in the center, and on the healing abutment, I'm just actually removing bone that's over top. And you'll see it flick off here in a minute, right right there. It's flicked off. There we go. And that's actually bone that was inside there. We're able to remove that off of there and not worry about thermal because of the water. Look at all the water here. If you're using a diode, stop every 20 seconds. Wet the tissue because the heat can build up heavily. And if you're using a CO2 laser, I'd strongly encourage you to be careful. Okay. There's the uncovery. Impressions like I showed you, same day. Impression, and the same size healing abutment that's put in. So there's the healing abutment put in. The patient returned. There's the tissue. Look how nice the tissue is 2 weeks later. And we're then putting in the final restoration. Here's the final restoration in place. When you want to save the tissue or move the tissue, Arnabat and his group out of Spain, great guys, they did a study, and what they did is they looked at moving and sliding the tissue overlying the implant to the buccal. This was done to increase your amount of keratinized tissue and to increase the volume of tissue to the buccal aspect of the implant. So here's a case, 3 implants. This was done many years ago. 3 implants placed, and I want to uncover them on the day of. And what we did is on the front one, I had enough keratinized tissue. So I actually just did a manhole. And on the 2 other ones, I did a U-shaped where the buccal is still intact, and I slid the tissue towards the buccal. So you see me taking impression for provisional restorations. And you'll see here, I put healing abutments in, the patient returning 2 weeks later. Here's the patient returning 2 weeks later. And you can see the tissue is just sitting on the outside of the buccal. Here's in the middle picture, you can see the amount of attached tissue that I've been able to slide over to the buccal from that was previously overlying the occlusal aspect of our implants. In this case, again, it was a splinted case. Wouldn't do this now, I don't think splinted, but it was a stock abutments and a splinted case, cemented restorations over top, and you can see the final case here. And the radiographs of the case, you can see the posterior implant was a crestal lift, and the 2 anterior implants are non-crestal lift. So in the last 10, 15 minutes, I'd just like to cover a little bit on peri-implantitis. And I want to go through this and just explain what. Yep.
Yeah, we probably only have about 5 minutes or so. So we'll go over this real quick.
All right. So I'll just show you quickly.
Yeah, perfect.
So what I'm going to do, I'm just going to go through it and I'll just show you where we stand right now. I'll just tell you that when you look at articles on peri-implantitis with lasers, there's a lot of them that have been published in the last 5 years. What's the definition of failure? I'm often fond of saying an ailing implant is not the one that you did, and a failing implant is the one that the guy across the street did. That's not the way it works. You know, a failure is implant that has pain, it's got mobility, it's more than half of the implant is lost. Please take those out. You know, this is not what we're trying to solve. Peri-implantitis is different than mucositis. Mucositis is in the soft tissue. Implantitis is in the bone. And when you look at the causes, or actually the etiology, what this study showed is that roughly 2/3 of participants and 30% of implants had mucositis, and 1/5 of participants and 10% of implants had implantitis. So it is a problem caused by poor oral hygiene, occlusal overload, lack of keratinized tissue, smoking, excess cement, and systemic factors, as well as placement of the implant. So I'm going to go through this. I'm not going to do this one. What I will tell you is that closed flap has little success. So if you're doing closed flap, especially with a diode laser, don't expect much success. An open flap is typically what is done. So I'm going to go through the open flap. I'm going to go through the open flap case just to show you what is done. Closed flap can be done with closed flap can be done with the ND-YAG laser. Typically what's looked at now as a standard of care is that you need to identify what caused the problem. You need to have primary wound closure afterwards. You need to remove granulation tissue that's in there. So you need to get that out. And the laser or titanium brush is absolutely vital for this. And you need to disinfect in order to get the bone growth back on your implant. And that's where the two steps are: debridement and disinfection. That is really where the laser comes into benefit. So it's been shown repeatedly that the laser can remove biofilm. It's been shown that the laser can remove tie unite surfaces. You'll see that here in this study. You'll see the laser has been used to remove the tie unite on the implant and get back down to solid titanium. Be careful with heat. All tissue lasers with their water can control heat. And we've shown re-osseointegration can occur, meaning that bone can grow back onto the implant when you do this. It's been shown in dog studies by Nevin's group, which are very well known in the International Journal of IJPRD, to be able to re-osseointegrate to the implant surface. So we've seen that in dogs. And we now, in the last couple of years, are seeing many human cases. I'll show you two cases here to close. This is from their most recent article in 2021, where it looked at utilizing the Erbium laser for very severe cases that I would suggest you would extract. So this is their study. They can look at this case. This was a posterior implant. And rather than remove all the granulation tissue and grafted that area, look at the severe. You have to use it.
Glenn, we're kind of losing you. I don't know if your internet is going down or what. Whoops, I guess we did.
Looks like we lost him.
We did lose him. All right. So anyway, hopefully you'll get back on. I appreciate everyone staying to the end. Again, we apologize for the technical difficulties. Some good questions about settings. I'm going to give you my email address because Glenn didn't get a chance in case he gets back. Our goal with laser dentistry is always to use the least amount of energy to do the job, and it limits what we call the zone of necrosis. So I imagine most of you have diodes, or the majority of the listeners are diode users versus Erbium because of the cost. Typically, I start out at about 1.2 watts, and that would be for tissue recontour and gingivectomy, and also for troughing. And again, that diode laser is attracted to dark pigmentation, melanin or hemoglobin. So if you've got someone that's Afro-American or Mediterranean, typically our diode setting will be a little bit less than someone like me that's Northern European. So I start at 1.2. If it's dragging, then I turn it up and I just pop it up, usually 0.2. So if it's dragging at 1.2, I'll go to 1.4. If it's dragging at 1.4, I'll go to 1.6. If you go in and I use Picasso Light, the default setting is 1.8, which I think is really too high. You can change the default setting on your laser itself. Is if you're cutting and it's smoking like you're burning a cheeseburger at the beach, you might as well use an electrosurge. I mean, that's back to the heat, and you're getting a zone in